students, welcome to the platform of eGurukul and Dr. Bhatia Medical Coaching Institute. In this video, I am trying to, address some of the controversies in OBGYN. To be frank, I also get irritated by these controversies which I see in OBGYN. But yes, I try to compile and try to speak about those controversies in one place so that you'll have a clarity. So let us see how much I'll be able to help you in this. So first amniotic fluid. So one question which constantly students ask and always a confusion is, when do we have maximum amount of amniotic fluid? So maximum amount of amniotic fluid, remember guys, 32 to 34 weeks of gestation. And if I have to go with one number, please go with 34 weeks of gestation. Many studies have given 34 weeks having the maximum amount of amniotic fluid. So if you have to go to range, go with 32 to 34 weeks. You have to go with a single answer, please go with 34 weeks of gestation. Okay, this is the point number one. Point number two, how much iron to be given as a prophylactic. So now we are following Anemia Mukt Bharat, and irrespective of Park or irrespective of Williams, wherever it is. So according to Anemia Mukt Bharat, earlier it was 100 milligrams of elemental iron according to the National Immunization and all, Indian Health Ministry and all. That is outdated, guys. We are no more following that. Now we are mainly following Anemia Mukt Bharat. So in pregnancy, now we are supposed to give 60 milligrams of elemental iron starting from the second trimester. So 60 milligrams of elemental iron plus 500 micrograms of folic acid for 180 days in pregnancy and 180 days postpartum. Okay, this is the second point. So according to Anemia Mukt Bharat, now the how much we are supposed to give is 60 milligrams of elemental iron for 100 and plus 500 micrograms of folic acid for 180 days in pregnancy and 180 days postpartum. Okay. Next, coming to the third one. So third controversy which I have repeatedly got the question was regarding the early cord clamping. So the early cord clamping indications, ideally you should always do delayed cord clamping. That is, you have to wait for the cord pulsation to stop and then you have to cut the cord. So when you do delayed cord clamping, the baby will get extra 80 ml of blood. But where we are supposed to do early cord clamping is when mother is hemodynamically unstable. When there is fetal distress, when there is cord avulsion, like in vasa previa or abnormal Doppler or placenta previa, or in abruption. So wherever cord circulation is not intact, you should go for early cord clamping, right? So vasa previa, placenta previa, abruption, so where the cord circulation is not proper, or whenever you have abnormal Doppler findings in the umbilical artery. So like in IUGR, if you are having abnormal Doppler findings, then yes, early cord clamping. There is no purpose of delayed cord clamping. So abnormal Doppler in umbilical artery findings. Next, RH isoimmunization also, it is early cord clamping, guys. Actually, very recently one study has come where it has told, yes, in RH isoimmunization, delayed cord clamping is more beneficial. And I've been actually telling many times that delayed cord clamping for RH isoimmunization, to be frank. But yes, there's a correction for this. So according to the new guidelines, what they tell is, released by NCB. So they tell that RH isoimmunization may, although delayed cord clamping is more beneficial, but still we are practicing early cord clamping itself. So RH isoimmunization. HIV. Now HIV is also one thing which many students ask. HIV, it is delayed cord clamping, guys. HIV, it is mainly the delayed cord clamping. Okay, mainly according to WHO, according to British guidelines, NACO, everywhere it is delayed cord clamping. So HIV, it is delayed cord clamping. And again, HIV, we give exclusive we suggest breastfeeding in the HIV mother instead of bottle feed, because what they have observed is the infections due to bottle feed was more higher compared to the transmission to the baby HIV. So HIV mothers can do breastfeeding to their babies. Okay, so these are some this is about one more so here about the early and delayed cord clamping I've discussed. Next, coming to the vesicovaginal fistula and perineal tear. See, whenever you have 3rd and 4th degree perineal tear, guys, don't you think it is a contaminated wound? Right? It's a contaminated wound. So obviously when it is a contaminated wound, so you will have the fecal matter there, and if you have detected beyond, so both of these, if you have detected within 24 hours, repair immediately. Repair immediately. But if you have detected after 24 hours, now by now the infection has spread, so it becomes a 3rd and 4th degree perineal tears now become edematous. The tissues have become edematous and it has become contaminated wound. So when it is a contaminated wound, can you repair anything which is in sepsis? It's a common sense, yeah. Like when there is an infection, a local infection. Personally, I have found out this with other seniors. Even I go through this RCOG also, so I find out with my other seniors also. So even in our experience, so they have done, like if you do immediate repair when there is a fecal soiling, they go into sepsis. The wound will disrupt and it will be more horrible. So first you have to let the edema of the tissues, let the sepsis, everything come down. You have to divert the fecal matter and the sepsis, all this has to come down, and then you can repair it. So perineal tear should be repaired, which is detected late should be repaired after 3 months, guys. Whereas vesicovaginal fistula, this is not as contaminated as your perineal tear or fecal contamination. It's not so horrible. So even detected after 24 hours, you can repair after 6 weeks. Okay, so I tried to keep this video short and I spoke about some of the common controversies which I keep getting message multiple times. If any other controversies are also there which I should address, let me know in the comment box. I'll help you out. Okay, guys? Thank you so much. See you in the next video. Thank you so much.